So this is going to be about a quick 15-minute update on upper urothelial tract cancer, upper tract cancer. These are my disclosures. I've underlined the relevant ones. QED makes a product called infigratinib that I'll be talking about. Urogen, you'll hear about the Jelmyto trial. I'm going to talk about some new data from Checkmate, study from BMS, and that's about it. So let's get on with it. So I'm going to talk first briefly about the Olympus study because Dr. Linehan, who's following me, will get into this in more detail. So huge unmet need, patients with particularly larger volume, low-grade disease in the upper tract often end up with a nephrectomy, nephroureterectomy. And so this was a single-arm prospective phase 3 trial of Jelmyto, which is a thermoreversible gel that's it's essentially viscous at cold temperature, and you inject it admixed with mitomycin C, and it forms a gel up in the renal pelvis and infundibulocalyceal system, and then dissolves over about 4 to 6 hours, essentially retaining the mitomycin up there. So the trial was for biopsy-proven low-grade disease, no high-grade cytology, and the treatment was administered through a retrograde ureteral catheter into the renal pelvis weekly for 6 weeks, and then within 4 to 6 weeks after the last administration, the primary endpoint was ureteroscopy and biopsy and elimination of an index tumor of 5 to 15 millimeters. And then patients who had a complete response could then go on to get monthly installations out to a total of 1 year. And we've reported this in Lancet Oncology just about a year ago. The intent to treat population was 71 patients, and that was anybody who got at least one installation. The complete response rate overall was 59%, and it was the same in patients who had both resectable and unresectable. Most of those patients with unresectable disease had disease in the lower pole infundibulum, which, as I think everybody knows, can be a little bit challenging to reach. So this far exceeded the expectations that we had set when we were presenting this to the FDA from the trial design standpoint. I think the most significant adverse event is ureteral stenosis. Most of those were easy to manage with stenting or dilation, but there were a handful of patients that ended up getting a nephrectomy in part because of recalcitrant obstruction. Durability was a key secondary endpoint, and this is a Kaplan-Meier plot showing an 82% probability of maintaining a CR at 12 months, and we've got a manuscript in preparation that'll be going into that in a bit more detail. And like I said, Dr. Linehan will, I'm sure, be getting into the data in more detail in her talk. So going to move on to neoadjuvant therapy. So you can see up in the right kidney a filling defect. This happens to be a patient that I did a cystectomy in a neobladder before, and even despite adverse pathology, has done quite well. He got adjuvant chemotherapy, done well since, presented with gross hematuria, has that CT scan, and pathology biopsy showed high grade, looked sessile, higher probability of invasive cancer. What would you do? So we and many other people have been doing neoadjuvant chemotherapy, just like we do in the bladder. Followed that with a nephrectomy, nephro-U and an RPL&D, and had only residual TA high-grade disease and has done well subsequent to that. So the rationale is based in part on the level 1 evidence from lower urinary tract cancer. I think everybody's familiar with that. And you can use certain features, most notably high-grade sessile, certainly size, CT, MRI appearance, to try to identify patients who are more likely to have invasive cancer, higher risk of occult metastatic disease. And the idea is you treat at the time that they have maximal EGFR. I'll get to the POUT study shortly, but when you look post-nephrectomy, you obviously see a significant drop-off in EGFR that may mitigate the probability or minimize the probability that a patient could get cisplatin-based chemotherapy in the postoperative setting. The retrospective data to date arguably are hypothesis generating. These are some of the data out there. These are several series that have been reported previously. And I think one of the things to point out is that the complete response rate, so pathologic CR on the nephrectomy specimen post-chemotherapy, at best ranges from about 10 to 15%. The smaller series from MD Anderson at the bottom looks a little bit better, but that may just simply be a reflection of the small sample size. So it's different. We're not seeing the same degree of complete responses that we see in the bladder, which is closer to 35, and in some series, 40%. The guidelines do address this. The EAU just updated their guidelines recently, and now have a strong recommendation for adjuvant chemotherapy based upon a trial that I'll show you shortly. But lower level evidence in terms of improving overall survival. ICUD addressed this in guidelines published in 2017, and the French guidelines also address the role of perioperative therapy. We rely, as I'm sure you do, a lot on the NCCN, and within the bladder guidelines, they do address the management of upper tract tumors. They consider neoadjuvant chemotherapy in select patients, and the recommendations are identical for renal pelvis and for ureter, and these are the chemotherapy regimens that are recommended: Dostance, MVAC, and gemcitabine, cisplatin. An older regimen of CMV, cisplatin methotrexate and vinblastine, was primarily used in Europe. It was one of the regimens used in the international trial. That was one of the large phase 3 trials that showed the benefit of neoadjuvant chemotherapy, predominantly in lower urinary tract disease. Some more recent data looking at pathologic response. This is a series from Johns Hopkins. The hatch bars represent the neoadjuvant chemotherapy treated patients. The open bars are no-NAC. And in general, again, you see that path CR rate of 10 to 15%, which is pretty consistent. And overall path stage was lower with neoadjuvant chemotherapy. Unfortunately, just because you achieve a pathologic response doesn't necessarily always translate to improvement in overall survival, though one would argue that it should. This is an updated systematic review that was published in European Urology just a year ago, showing in the right here a benefit to neoadjuvant chemotherapy, and then here's the data for DFS and OS, again suggesting a benefit, but these are hypothesis generating by nature because there's very little prospective data until recently. So ECOG did a phase 2 trial, EA8141, led by Vituli Margolis and Jeannie Hoffman-Sensis, who's now been at Hopkins now for a while. This was the trial design. It took patients with the aforementioned criteria I mentioned that I've listed for you again in the upper right side, again enriching for patients who are more than likely to have an invasive cancer. If you had an adequate EGFR greater than 50, you got Dostance MVAC. If it was less than that, you got Gem-Carbo. Not a regimen that we typically use for urothelial carcinoma because it's felt to be inferior to Gem-Cis. And I think that was one of the reasons why that arm didn't accrue very well, only 6 patients. But again, you see the 10% PT0 rate. Overall path CR was 14%. Kaplan-Meier plot just shows how the two patient populations did over time, and they're planning a follow-up trial to this with chemotherapy plus IO that's in development. And so we'll see and that'll be offered through the NCTN. Just a comment about Lynch syndrome. I think that the audience should be aware that pembrolizumab is approved as an FDA approval agnostic to tumor type or organ site based upon MSI high or mismatch repair deficient solid tumors, the hallmark of Lynch syndrome. And we recommend considering this for a solitary kidney. This is just a patient of mine. I think many of my colleagues have many other patients. This is a lady who had a nephrectomy 10 years previously. When I saw her, she had large volume disease, was able to ablate it, but not completely, and I recommended a nephrectomy. She refused, and she's been on Pembro now for about a year and a half. And I can tell you, I've been up there twice, and it's a complete response. Biopsy negative, cytology negative. So keep this in mind, particularly in the patient with a solitary kidney and documented Lynch syndrome. So now we're going to go to adjuvant therapy, so postoperative therapy. Based in part, some of the rationale is, we obviously have a lack of accuracy of clinical staging. We think we have a problem with the bladder. We've got a bigger problem with clinical staging of the upper urinary tract, and then you can rely on pathologic staging with a nephrectomy specimen to identify those high-risk patients. The EAU guidelines based upon the POUT trial give a strong recommendation now for adjuvant chemotherapy level 1B. So this is just some retrospective large series. This is predominantly from Europe. Andrea Necchi published this and his colleagues showing no benefit to adjuvant chemotherapy. And then this series published in JCO in 2017 suggested a benefit in both for overall survival. But there's no substitute for a randomized clinical trial, and that's the POUT study. This was published in Lancet Oncology. Alison Bertle was the PI. The eligibility you can see there. So this is post-nephrectomy, pathologic stage T2, T4, and any, so either positive or negative nodes, but no distant metastatic disease, predominant urothelial, and able to receive chemotherapy within 90 days. This is just a description of the group, and this is a randomized trial, chemotherapy versus no chemotherapy. And then here's the data. You can see that there was both a benefit in terms of disease-free survival and metastasis-free survival, but they have not reported OS data, at least that I've seen in the peer-reviewed literature. If you look at the subset analysis, benefit appeared to accrue a little bit better to N0 patients and patients treated with Gem-Cis. But I think that it's imperative that we discuss this trial results and make chemotherapy available in the adjuvant setting to patients who did not get neoadjuvant chemotherapy. I think we have an obligation to discuss level 1 evidence with our patients. So just a final mention, this was reported by Dean Bajoran. This is Checkmate 274 from BMS. I do have a consulting relationship with them. So this was a randomized trial of adjuvant nivolumab, and the reason I'm presenting it in an upper tract session is they included upper tract patients. You can see the eligibility criteria. They did a stratification by PD-1 status and also a pre-planned analysis by both all comers and PD-1. And I'll just get to the Kaplan-Meier plots because both of those analyses were positive for disease-free survival. They have not reported overall survival to date. And this is the subset analysis. And again, I just want to call to your attention that I think it was about 20% of the patients had upper tract disease. And even though that didn't suggest a benefit here, you have to look at the overall trial results. Now, you can't go out necessarily and use Nevo in this setting because it doesn't have an FDA approval for that. But this could be coming down the pike, and there's an ongoing trial of pembrolizumab in the cooperative groups, and the trial with atezolizumab was a negative trial. And then finally, the QED study has infigratinib, which is an FGFR inhibitor. This is the schema of the drug on the top left. This was some data on a metastatic study that they presented, overall survival there. And this is the adjuvant trial. So this, again, is the same high-risk patient population, but now they have to have an FGFR3 alteration. And if they do, then they're eligible for the trial, and it's a randomization to infigratinib versus placebo. The SUO is making a major contribution to this trial, but it's a big global trial and underway. So the idea of using a targeted therapy, why FGFR? Because we know it's mutated, or there's fusions that result in high expression of FGFR in up to about 60% of patients, even with high-grade disease in the upper urinary tract. So in summary, we've got Jelmyto, FDA approved for low-grade disease. We've got some emerging data for neoadjuvant chemotherapy. Keep in mind the approval for Pembro in patients with Lynch Syndrome. We now have level 1 evidence supporting adjuvant chemotherapy, both platinum-based and carboplatin-based. Stay tuned for the OS data on adjuvant trials, and I hope that if you have a patient who you think may be eligible for the QED trial, there's centers all over the country that are doing this, and probably one close to your place. So thank you again, and I appreciate it.